I guess I'll just start by saying it ain't over. So I know Mona was like, what are you going to do now, Noreen, with all your time? Am I not going to get any more trips to Edmonton? Like, what's up here? So I just want to say that we've built a foundation, but we're together. We're now experts, and we're passionate about this cause, and we're going to continue to build. There's going to be continued improvements, so I think all the sites, including Foothills, including Grey Nuns with their 10-minute door-to-needle times, we can all still improve, and we're going to continue to do so. We're going to be peer supports to those sites that need it, and we're going to make that entire heat map a really, really deep green and really show the world that every single site in this province and every single patient is getting access to the best care possible. So in terms of continued improvements, I just want to say that we are not there yet. I know that we are sort of celebrating how good we are when it comes to our peers in the United States and in Europe and even in other provincial jurisdictions. But we really have not reached our goal of a 30-minute median time. And I really, truly believe that we can, and I think you guys do as well. So I know many of you guys are going around looking at the posters, and we will post all the posters on our website. But just to think about what have other sites done that we have not done that can be applied to our site. How can we reduce variation at our site? So I think Tom asked that question about locums. Is there a short 7-minute presentation that we can make at QuiCR that we can then have available for you guys to sort of in-service in all new locums as they come in? And I think it's about making strategic alliances, right? So I think, you know, we've been picking on the emerged docs, but we have so many emerged docs sitting here, and we're preaching to the converted. So how can we leverage that to get emerged docs in other jurisdictions in this province that are not on board to get them going, right? So you know, maybe it's about how we build these alliances between each other, how we actually get nursing and how we get diagnostic imaging. For example, there's a few Philips scanners around this province, and we know how to deal really well with GE and Toshiba. But you know, we'll work together and make sure that we can get images just as fast to us, available through the Philips systems as well. So it's about understanding all this. It's about continuing our engagement of Rapid to get as fast telestroke consult as possible, continuing our alliances with the stroke neurologists, and ensuring that we have fast response. I'm going to talk a little bit around implementing your changes, okay? So I know you guys have all made changes, and I just want you guys to consider if they've actually been implemented into your system or if they're dependent on a particular resource or a particular time of day, okay? So you need to make organizational change within your hospital, within your zone, within our health system to actually implement those changes. So are those changes dependent on a particular person? If the answer is yes, your changes haven't been implemented, okay? They have to be systematized into your system. You have to have the order sets, the algorithms, the checklists available for your registration clerk, your triage nurse, right as you get your pre-notification so they can pull it up no matter who is working, and you can get that fast flow through your system. I think Dr. Bestard was talking about how they've actually put it as part of in-service training or annual training. So how many of you guys have annual training now on your new stat stroke process? So you guys have to start to now think about how you're going to create annual training for all these changes, so when Pam at Fort McMurray moves on and starts running some great big hospital, because we know she can, that Fort McMurray doesn't fall down and go back to 70-minute door-to-needle times, right? You need to create algorithms, protocols, policies, and procedures. There shouldn't be anyone saying, well, I'm doing this off the side of my desk. This is not part of my role to be doing this. So if there are people saying this, you need to talk to your managers and say, we need to update our job description to include this within the role of this person, okay? So really, we need to ensure that we have embedded all of your changes so that there's a legacy in moving it forward. So that comes down to senior administration engagement and support. You know, we cannot do it without leaders such as Rob. We cannot do it without leaders such as Kathy. You know, so we need to work within our hospitals, within our zones, to ensure that we have our leadership support. And when there are barriers that are occurring at your hospital, we can turn to your senior administration. So if this becomes an issue for anyone at any of these sites, please talk to us. We'll work with the SCN, and we'll see what we can do to help get your senior administration on board. So here's some checklists. It seems like every time you guys come to a learning session, you guys are always planning. Oh, we've sat here and we've come up with some additional changes because we've got the whole team together. So I would encourage you to set up regular team meetings. You guys have your team now. You guys should maybe meet once a month or once every 2 months, depending on people's availability and how much improvement is actually required at your site. You guys should set targets. So by this date, we're going to have this fully implemented. We're going to make sure that we have our stat labs done for patients that are on warfarin. Okay? You need to create a list of additional changes that you still need to implement. You need to understand what changes have not been fully implemented and work towards implementing them. I hope that everyone's going to continue with data feedback. We are going to continue, but I think it also helps hearing back from the site. It could be immediate feedback once you've treated a patient and you know their door to needle time. Let the entire staff, let all the physicians know what that door to needle time was. And let them know about the bad ones too and what could have been done to improve it, right? I think that there's a lot to be learned from immediate data feedback. You need to spread the word. So you need to spread the word locally. If there's people coming in at your site or even folks that are not fully on board yet. So we will continue to do site visits. If you want to have meetings without QuiCR being around, certainly we encourage you to do that. And I've heard over and over again that there's a community hospital without a CT scanner that doesn't communicate to you that they're sending in a stat stroke patient. They just communicate with diagnostic imaging. So we should all think about how we're going to get these hospitals on board. I think we can do things centrally within QuiCR, but then you can also be going out to these sites and educating them and working and building alliances with your referring hospitals. QuiCR is not going to go away, okay? Even after our funding runs out, we're going to make sure that we build in sustainability plans, and we've got your back, okay? So we're always going to be here. We're going to work strategically with Alberta Health Services and the strategic clinical networks and ensure that we continue on with this work. How are we going to do that? We're going to do that through the QuiCR registry. It's going to have mechanisms for continued data feedback that Michael was talking about. We're going to build some door-to-needle dashboards that's going to be available to everyone. We're going to integrate it with Alberta Health Services data. We're going to continue our activities. So we'll continue with the site visits. If you do want it, you please ask, okay? We're going up to, or down, I guess technically, Lethbridge on October 3rd. So we're looking forward to that. You know, some other sites that come to mind, I think we went to Grand Prairie a bit too early, and we should come back and have a larger meeting with your physicians and nurses up there and diagnostic techs. You know, so those are two that immediately come to mind, and I think we should just continue. Medicine Hat as well is another one. I think if there's interest and if there's topic areas that people do want to know about, we can continue in webinars. It's a really low-cost, easy way for people to gain access to education and new information. And, you know, I think Michael will talk about this more and what sort of meetings we want to continue to have after this. You know, where we should be focusing and how we should be bringing people together such as this and what we should be working towards and talking about. We're going to continue to improve the telestroke service, work with RAPID, the PSCs, and the stroke neurologists, and further streamline the process. We all know this process, and we certainly talk about sustainability, but we should also talk about spread, okay? So like Kara and I were at the Canadian Stroke meeting and really saying that this is possible across Canada, and it is our role as leaders in the world to really encourage the rest of Canada and the world to reach these goals. And maybe an achievement would be to have another jurisdiction beat us, right? So we shouldn't see that as a failure, but we should see it as a success because we actually enabled other jurisdictions to get to the level that we're getting at. I'm just going to present to you the IHI Sustainability Guide. It is available on the web, and you can download it through the IHI. If you just Google Sustainability Guide, it should come up. But the first part of it talks about these 6 key components of sustainability. So that's holding the gains. And I think I've talked about the first one already. You need to have supportive management structures. So you've been able to do a lot at the grassroots level, but unless administration and management is there for you, probably you will start to see slippage in your door-to-needle time. So if you feel that your administration is not on board right now, I really encourage you to set up meetings with them. If you want the SCN or QuiCR to help you with that, if there are deficiencies in that area, please let us know. You need to have structures that are foolproof change. Okay, so you need to think about where are the failures within your door-to-needle time. So it might be locum physicians. It might be the telestroke. It might be not knowing where the TPA is, and you haven't created your TPA kit, which I don't think anyone in this room has. But to understand where those deficiencies exist, and then to make sure that it can happen. Fast treatment can happen for every patient every time. So if you say, oh, well, that patient had high blood pressure and we needed to manage it. Well, maybe it's because you didn't have the medication available in your TPA kit and you could have managed it a lot faster, and that patient could have had really fast door-to-needle times. You need to have robust, transparent feedback systems. So it's not about protecting feelings. It's about being really honest with the data and really letting people know what their performance is. It needs to be a shared sense of the system that needs to be improved. So, when we look at certain teams that are performing really well, Red Deer and Westlock, everyone is on board. There's this real sort of engagement and a sense of ownership of the system, right? So that's there needs to, and feeding into that, the culture of improvement and a deeply engaged staff. And a lot of it might be like the October 3rd meeting in Lethbridge and getting everyone on board and getting them excited about this and showing them that they can do it. You need to have a formal capacity building program. So this 7-minute video to train locum physicians. How are you going to build capacity within your hospitals to ensure your entire interdisciplinary staff are aware of your new systems that you've put in place? So let's talk about the supportive management. So that was the first one. So that includes board and executive teams creates accountability systems for tracking performance. Is your upper level management, is your site manager engaged in how accountable you are in your door-to-needle times? And if not, why? Assigning senior level responsibility for holding the gains, campaign interventions and reviewing intervention level performance monthly, or maybe after every case in a structured reporting format. You need your board and executive team to effectively communicate measurable improvement aims and the importance of sustaining performance in the intervention areas, utilizing key communication vehicles. So are you doing mass emails out to people? Are there newsletters every time you have achieved something? How about hospital meetings? You need to emphasize the importance of this work at these meetings. Executive team celebrates sustainable attainment of improvement aims. So how many of you guys have boards set up where you are celebrating achievements that you've made at your site? Foolproof structures of change. So managers of improvement, which are you guys, document your activities of successful processes in guidelines and training material, right? So we've talked about this. Managers of improvement activity, that's you again, develop tools. So these are checklists, prepackaged kits of material applying to the intervention, and technology to support implementation of the intervention. Robust, transparent feedback systems. The hospital has in place a measurement system that regularly generates data on performance. So we will help with that with the registry. And I know many of you guys are doing fantastic work with data feedback. We need to make sure that you do it across the level. Don't be shy of the managers and executive at your hospital. They need to know about this. The hospital publicly displays improvement data on all improvement interventions. So we've seen some of the successful sites doing this, right? A shared sense of systems to be improved. The team uses tools to map the process that has been improved. Show them the new process, map it out, flow charts, allowing for shared analysis of systems as sustainable work spreads. A culture of improvement and a deeply engaged staff. Everyone in the organization is clear on major performance activities. Everyone should know exactly what you're doing, right? And can explain their role in it. What part does a DI tech, random DI tech, play in the door to needle times? They should be able to say what that is. Staff view quality improvement as part of their jobs. So no one should be in your hospital thinking that this is off the side of their desk. This is their job, okay? The team writes job descriptions to reflect involvement in introducing a particular intervention, okay? Managers of improvement activity create opportunities for all stakeholders to express concern. So you need to have an open and honest system where people can express concerns around the new changes that are happening. And sometimes it's hard. Sometimes you feel like you should just dictate down, but they may have good reasons for why certain changes may not work. And people need to be heard. Finally, formal capacity building programs. The team should closely consider the composition of skill base of participating teams. Does everyone have the skill at your hospital? Is there some training, extra training that's required on the EMS level? Is there stuff that AHS can help with? Every stakeholder in the organization is introduced to the content of any new improvement initiative. And then it's all about spreading the interventions to all locations. So we've laid the foundation right now, and we now need to spread it, developing an initial plan for spread, and then refining that plan. So that's all I had, just a few slides, but I think you guys really need to think about how you're going to implement this such that the improvements can continue and foster and sustained. That's it.